Well, hello. I'm Morgan Micheletti.
And I'm Nicole Bajic, and welcome to Hot Takes with Nova Eye.
Yeah, I mean, we'll start off with some easier, we'll say some mild questions. We'll move into medium, and then we'll get a little spicy.
What is the moment in a case where you think, yeah, this is why I do canaloplasty?
For me, yeah, I think there's two specific things I see with iTrack Advance. It's when that lit lumen first starts traversing transsclera. You start seeing it through the conjugate sclera, and you see that you are in the canal tracking beautifully 360. That tells you I'm in, I'm good to start delivering OVD. And then as I'm retracting the cannula and we're delivering those clicks of OVD and watching that blanching, it is a very reassuring sign and just one of those moments where you're like, yes.
And also it's just really nice to know where you are with that light.
Instead of having to wait for the patient to go, ow, right? Which we've all experienced, sure. But you have that constant light level feedback that's providing that visual.
And now it's green, so it's even easier to see.
That's right, that's right. So what's the biggest misconception about MIGS that you hear from colleagues?
There seems to be this idea that it should only be in the hands of those that went under a formal glaucoma fellowship. We need all hands on deck. Any patient that has glaucoma should be getting MIGS, and it's a shame and a disservice to them, especially because at this point it is standard of care, and if we're not offering it to their patients, then you really should be referring to someone who does do it.
The biggest misconception about MIGS is thinking that it is not already the standard of care.
Canaloplasty has been around for years, and the data keeps getting stronger. So why does it feel like the underdog in the MIGS conversation?
I think it's gaining more and more momentum. I think a lot of surgeons, especially as they are getting introduced to the angle, are looking for that implant-free option as the first go. And if you look at the IG protocol, tissue sparing and canaloplasty are great options.
Okay, we talk about keeping options open for our glaucoma patients. So how many surgeons actually think about that during their first intervention versus just reaching for what's familiar?
If you look at the IG protocol, non-tissue sparing MIGS is one of the last things on the menu. So often, surgeons will reach straight for goniotomy, right? And in mild to moderate glaucoma patients, that's not first line, right? When we move into severe, I think that's a great place for goniotomy. But everywhere before that, tissue sparing is first line. All right, are you ready to get spicy?
I am so ready, born ready.
All right, some people say that MIGS is overhyped. Do you agree or disagree?
I'm gonna have to say I'm guessing the ones saying that are the ones that have never done them before. We know that compliance is a big issue with patients, as everyone on this planet will need cataract surgery, it's just a matter of when. That represents a moment of time, that's their one shot to have an intervention with 100% compliance. And so why would you not take advantage of that? And it works so well.
Absolutely. 50% of patients self-discontinue medications after 6 months of use.
That's not to mention the peaks and troughs for medications, right? But this is working 24/7. Okay, are you ready?
I think so.
So, if canaloplasty treats 360 degrees of the outflow pathway and a stent only treats a few millimeters, why are stents still the default first MIGS for so many surgeons?
I don't look at this as an either or. I really think a lot of our angle procedures can be synergistic. If canaloplasty can dilate the canal and distal collector channels, what are some ways we can also bypass the trabecular meshwork? I think surgeons often go to perhaps a stent first because in their mind it's thought of as perhaps a more straightforward procedure. I think with a few sessions of a dry lab or a wet lab, they'll see that canaloplasty is also straightforward once you're comfortable in the angle. I'm gonna let you choose one of these since there's two left, and you can ask me the other one.
All right, let's do that one.
All right, here, so you can ask me that one after. All right, a patient asks you, why are you recommending canaloplasty instead of the one my friend got? How do you handle that conversation? I think we address this in IOLs all the time, right?
Yeah. So listen, everyone's eye is different, and at the same time too, you want your surgeon to use what's best in their hands and what they've seen the best results with. And people have their preferred devices for various reasons. But what I think is special about iTrack is the secret sauce, right? So with that shear clear, you can really get the viscoelastic through the collector channel and get distally and really open up the resistance. And at 100 microliters, it makes a difference.
I love it.
All right.
All right. Final one, here we go.
You have 30 seconds to convince a comprehensive surgeon to try iTrack Advanced. Go.
Wow.
Clock is ticking.
Listen, you've got to learn how to do this, first of all, because tissue-sparing MIGS is one of the first line treatments in the interventional glaucoma protocol, right? So it is something you need to learn. It's going to help your patients, and if you haven't gotten involved in MIGS, this is a great entry point because it's it's tissue-sparing, and you're not leaving something behind. So if you're not quite comfortable with that concept yet, this is a great early device or a great early option for you to get involved in the space. Well, Nikki, always a pleasure getting to chat and hang out with you. Any closing thoughts?
More and more the conversation has been that MIGS is now standard of care. So get started, get comfortable because it's here to stay.
I agree. I think one of the biggest turning points in the last couple of years is the passion that has now really come around MIGS to where people are saying you really need to offer this to your patients. It is standard of care.